And just an announcement of the winners of the lucky draw, which was at the Parker Pen counter. The winners are requested to collect their gift from the Parker Pen counter after I've announced their names. Mr. Shishir Gorle and Noshi Ahmed. Shishir Gorle and Noshi Ahmed. If you can hear me, please go to the Parker counter and collect your gift. You're the lucky winners of the day. May I request those in Shah Jahan to please head back to their bar and take their places for the last session of the day on diabetes. Ladies and gentlemen, our last session for the day on the challenges and solutions facing the diabetes pandemic, and features as speakers Dr. Edward Horton, Professor, Harvard Medical School, Dr. Anup Mishra, Director and Head of Diabetes and Metabolic Diseases, Fortis Hospitals, and Wasim Akram, former Pakistan cricket captain. Moderating the session is Health Editor, Hindustan Times, Sanchita Sharma. May I request you to please take your seats quickly, kindly keep your mobile phones switched off, and we're ready for the session with Sanchita.
We have a box of chocolates right next to us, which is very, very tempting. I think we should put it away. Right. Good evening, ladies and gentlemen. Welcome to the session on diabetes. We're going to talk about the diabetes pandemic, the challenges and the solutions ahead for us. And, well, the idea was to end the day on a healthy note, so this is the best way to do it. I'm frequently asked what has changed that makes diabetes so common now, because our parents and their parents before us, they had similar diets, they had fairly similar lifestyles, but now you have a population where you have diabetes affecting 7% of the world's population. And India is among the worst hit countries in the world. We have 50.9 million people affected by diabetes. And this figure is expected to double over the next 30 years. And I'm not just talking about India, but South Asia as well. So what is it that is causing the problem to grow so fast in this region? And it's growing faster than in India than in the rest of the world. Is it the stress of modern lifestyle, or is it that our diets are changing very, very radically, much faster than it was changing earlier? Or is it that we are not exercising at all anymore? I mean, we go to office, we sit before a computer, we have our cars to take us to the office and back, and that's the end of it. We hardly ever walk, we hardly ever gym. Or now you have new studies even blaming diabetes on things like air pollution, which was something which was unheard of a decade ago. And then again, you also have people blaming diabetes on our genes, because there are some races which are more prone to diabetes than others. So now we have an expert panel here who would be able to tell us what is it that's making this generation keel over and what we can do to protect ourselves from diabetes. Because blaming this complex disease on one reason would be an oversimplification. What we do know that a healthy diet and exercise makes a difference, and it helps us stay disease-free. It helps us not just prevent diabetes, but also manage it if we develop it. So we'll have Wasim talking about that, because he was diagnosed with diabetes when he was 31, and he was the captain of the Pakistan cricket team, and then he went on with his cricketing career and did very well. So we'll start with Dr. Horton. Would you like to go to the dais? Our first speaker is Professor Edward Horton, who's the professor of medicine at the Harvard Medical School. And he's one of the world's best-known experts on diabetes prevention. And he's the principal investigator for a couple of very big US studies. And he's going to tell us what we can do to prevent and manage diabetes.
Okay. Thank you very much, Sanchita. Good afternoon, everyone. I'm greatly honored to have been invited to participate in this leadership summit, and particularly to be able to discuss with you diabetes, which is truly become a worldwide epidemic and a major public health problem that we're all struggling with. And to start my presentation, I wanted to just show you this slide, which was actually prepared back in 2003 for the International Diabetes Federation Congress that was held in Paris at that time. And the estimate then was that there were approximately 194 million people worldwide with diabetes, about 90 to 95% having type 2 diabetes, what we used to call maturity onset diabetes, and about 5 to 10% having type 1 diabetes, or what we used to call a juvenile onset diabetes. We know that those terms are not pertinent anymore because we know that type 1 diabetes can occur at any age, and that type 2 diabetes is occurring younger and younger in our population. But back in 2003, the projection was that by 2025, the number was going to increase to 333 million, about a 72% increase in diabetes worldwide. And if you look at the map, you can see there are certain hotspots around the world. And one of them is in Southeast Asia, and particularly here in India, where it was projected to double within that period of time. And I can tell you that we're ahead of schedule. Now India has reached the status of having more people with diabetes than any other country in the world. So you're number one in that regard. And it is becoming a major, major problem for the society. Now, since I work in the United States, I wanted to show you some statistics from the U.S. Because this is now what we are calling a dual epidemic, because it is closely associated with the development of obesity in our population. And it's currently estimated that about 2/3 of adult Americans are overweight if you use a measure called the body mass index being greater than 25. Now, in this part of the world, 25 is probably already overweight, but in the U.S., 25 is the cut point between what is considered a normal weight and being overweight. If you're interested in calculating your own BMI, it is your weight in kilograms divided by your height in meters squared, and you can come up with a number to know where you come on this scale. Now, obesity is defined as a body mass index of greater than 30, and it's currently estimated that 1/3 of the U.S. population is actually obese. 24%, or 1 out of 4, have what is called the metabolic syndrome, which is a cluster of obesity, elevated blood pressure, abnormal lipids in the blood, and elevated blood sugar. And this is considered to be a very high-risk condition for cardiovascular disease and for the development of diabetes. There are currently an estimated 24 million people with diabetes in the U.S., or about 7% of our population, and 57 million with a condition called impaired glucose tolerance, which is a gray zone between completely normal glucose metabolism and diabetes, but is a group that is at very high risk for developing diabetes. And here's a particularly frightening statistic. The lifetime risk of developing diabetes for people born in the year 2000, so the 10-year-old children now, is estimated to be 33% for men, 39% for women, and for Hispanic women, a particularly high-risk group, as high as 50%. And we all know that in this population, cardiovascular disease is a major cause of mortality. So if you look at some of these figures in the U.S., currently there are 57,000 deaths directly attributed to diabetes. It's the number 7 cause of death in the U.S., but it's probably underreported, and it's estimated that there are 193,000 deaths linked to diabetes, and so it really moves up to the number 3 cause. And in certain segments of our population, it's 3rd or 4th. It is certainly considered the 4th leading cause of death in African American women, the 3rd leading cause in Latino women, and the 3rd leading cause in Native American women in the adult population. So if we look then, what's the impact of this on our healthcare system and the economy of the U.S.? 1 in every 7 healthcare dollars spent in the U.S. goes to caring for diabetes and its related complications. Our Medicare, which is the government and state-funded program for managing the poorer population, is 1/4 of the budget is currently spent on diabetes. And the estimated total costs attributed to diabetes, which includes both direct medical care costs and indirect costs, has gone from $98 billion in 1997 up to $132 billion in 2002 and $174 billion in 2007. And I hate to think what it's going to be in 2010. I don't know that figure yet, but it's just going up and up and up. So what's driving this diabetes epidemic? There are multiple causes, and I just want to mention briefly a few of them. First of all, we know that there are inherited genetic factors in diabetes, and unfortunately, most of us cannot choose who our parents are, so we are stuck with the genes that we have inherited. But there is a rapidly rising field called epigenetics, which is modification of genes by environmental factors. And we know that both low birth weight and high birth weight children are at increased risk for developing diabetes. The low birth rate children are probably mostly related to maternal undernutrition, particularly protein malnutrition, which can be a major problem in a country like India. And the overnutrition is related to the mother having gestational diabetes and high blood sugar levels during pregnancy. We also know that exposure to certain environmental toxins may be contributing, and there's now very good evidence that air pollution actually is a factor in the development of diabetes. But far and away, the most critical factor in developing diabetes is changes in our lifestyle. And this is one of the prices we pay for economic growth and progress throughout the world. Now, to illustrate this, I want to just show you a photograph that one of my friends from Amsterdam sent to me. It's a picture that he took on a street corner in New York City, and he sent it to me with a little note that said, "This is why you have so much diabetes in the United States." Look at this picture. Every one of the stores in the background is a fast food. There's Middle Eastern, there's a deli, there's Dunkin' Donuts, Taco Bell, Pizza Hut. And the gentleman in the center in the red shirt, obviously obese, he's eating while he's talking to his friend. But the individual in the foreground has a pot belly. He's got abdominal obesity, which turns out to be a major risk factor for diabetes and for the metabolic syndrome. He's going down a one-way street, and my friend said this is clearly a one-way street to diabetes. Now, the challenge we have is how to turn that sign around and reverse the process. And this is really what I want to talk about in my presentation. There have been many trials around the world looking at the strategies for prevention of diabetes. I've been very fortunate to have been a part of a program called the Diabetes Prevention Program. This is a large multi-center study, involves 27 different centers in the United States, funded by the National Institutes of Health. And it is studying more than 3,000 people at high risk for developing diabetes because they have impaired glucose tolerance. And there were 3 groups in this study. One group was treated with the drug metformin, which is usually the first-line drug we use for treating people with diabetes. The second was treated with an intensive lifestyle modification program focusing on a healthy diet, weight reduction. We asked everybody to lose and maintain 7% of their body weight, and increased physical activity consisting of at least a half an hour of walking or other equivalent moderate intensity exercise most days of the week. And then there was a placebo control group. And this slide shows in a life table format the development of diabetes over time. The control group developed diabetes at a rate of about 11.5% per year. Those on metformin had this rate decreased by 31%, and the lifestyle turned out to be far and away the most effective treatment, reducing the development of diabetes by almost 60%. The actual number, 58% risk reduction in this intervention. We also found several other things. High blood pressure was present in 30% of the subjects, and in the lifestyle group, it was significantly decreased. The second is that triglycerides were decreased in this group, and the third was that there was an improvement in the lipid profile. And we know that there was much less use of medication in this group. We've now followed these people for 10 years, and we're still seeing the long-term effects. So to wrap up, I want to point out that prevention strategies are critical, but once people develop diabetes, we have to focus on global treatment. And fortunately, we have new medications for managing this. This slide shows the number of medications that have become available since the 1950s for treating high blood pressure. For diabetes, we've only had insulin and a few agents for a long time, and then we went through a very, very dry spell. But now we have many agents that are coming and several that are in development. So to conclude, I would just like to impress on you that diabetes is a major global health problem which is increasing at an alarming rate. The underlying causes are multiple, and I've listed them here on this slide. The economic burden is a major concern for society, and stopping the epidemic will require concerted efforts by many elements of society, including public education, governmental programs, community planning, better health care. The bottom line is this is a societal problem and not just a medical problem. So I want to leave you with a message that I think it's time for all of us to get together to develop strategies for dealing with this global epidemic, and it is clearly time to act because we're losing the battle. The numbers are going up and up as we speak. Thank you very much.
Thank you. Thank you, Dr. Horton. It's interesting to know that lifestyle changes had a bigger impact on diabetes management than medicine. So, which is a good message for all of us to take home. Our next speaker would be Wasim, who was diagnosed with diabetes when he was the captain of the Pakistan cricket team. And this is when he was, bowling, and his bowling was changing the game within 1 over. And even after being diagnosed, he went on to become the first bowler to take more than 400 wickets, both in test and one-day internationals. And this he did when he was injecting himself with insulin 3 times a day. So we want to know how. I mean, you were the captain when you were diagnosed. How did it happen? Was it a routine
I got
test?
diagnosed in 1997. I was only 31 years old. I was at peak of my cricketing career. I was losing weight rapidly, and I was sleeping a lot. I was thirsty a lot. I was hungry all the time, and I was losing weight as well. So I thought I was getting fitter. Usually, when I was 30, 31, I knew what diabetes was, but only knew about diabetes that is associated with obesity, people who don't exercise. But my job was to exercise, to run around all day long. I used to go to practice at 9 in the morning, used to come back at 5 in the evening every day. So obviously I was stunned when I got diagnosed as a diabetic. I didn't know what to do, and obviously my wife, Homa at the time, really helped me a lot. Doctors helped me a lot. It took me 1 month to came out of that mental phase where I thought, okay, my cricket is finished, my life is finished, and I won't be able to play cricket anymore.
What were you told by doctors when you went to them initially? Did they tell you could continue with your cricketing career, or did they
I
say
went
you had
to
stay at home?
one particular doctor in Lahore. He said, if you can, you have to have insulin straight away. And that was a huge shock for me. To inject myself, I thought, who will do it for me? Will I be able to carry on my cricketing career with having 3 jabs a day? But doctor said, if you look after your sugar levels and for a month or so, you can play cricket. So it took me a month, and I remember in November 97, I got diagnosed in September end or October beginning. In November 97, I got picked for Pakistan team again. I rested for a month. It took me about 6 weeks to get my insulin going. First of all, I thought it will be painful. It was painful to have injections in my tummy, but I got used to it. And then I learned, in diabetes, you can be your own doctor if you know what's exactly happening with you. What I've learned, I used to get hypos where your blood blood sugar levels goes down, and you can go into coma as well. So, that was again a huge difference for me, in my lifestyle, that what to do. So I used to carry chocolates with me, and I went on to South Africa, played that series. It was a bit difficult. I started putting on weight, and everybody else told me, if you're diabetic, you will get tired quicker than any other person around you, normal person. I thought to myself, and I read about it a lot, and obviously with my wife's help, I realized if I have my sugar levels in control, if I take my insulin on time, check my sugar levels, randomly, early morning, under stress, or if I'm happy, what sort of fluctuation I have in my sugar levels. And I think that helped a lot. I started off playing. I've got 250 wickets in 1 days. After that, I've got 200 wickets in Test cricket. After that, it's all got to do with obviously me learning about the disease, me living with the disease, and I was exercising a lot more than anybody in Pakistan team at the time. If they were doing 5 laps, I was doing 7 laps. So I think I broke that myth that if you're diabetic, you get tired quicker. I didn't. Reason that I was looking after my health, and I've learned that at lunchtime, if I had to bowl after lunch, I have to skip my insulin because I'll be exerting myself. So in the beginning, I used to have my 4 units or 6 units, and then I used to get hypo. So after a month, I realized at lunchtime, if I'm bowling, I shouldn't be having my insulin. So I didn't. So that's how I have controlled my diabetes. I do go through my phases as a diabetic in a way that sometimes I don't feel like checking my sugar levels. Sometimes I do feel like having biryanis and food, our own food. But I reduce my food. I eat healthy food. I try to have less oil. And of course, exercise. Healthy lifestyle, exercise. I've been retired for a good 6 years now, but I exercise regularly. I go to gym in the morning, and I try to do cardio in the evening, and I try to be stress-free at time, and that's a
But
bit
as a
difficult.
sports person, when you were playing for Pakistan earlier, weren't you tested and screened, and didn't you undergo health tests routinely?
In our
Doesn't
part
it
of the
happen
world,
for the cricket team
not
as
in
usual?
cricket. I don't think so. In any sport, it happened in our part of the world. We never had a doctor with us. We never had regular checkups for Pakistan. I hope they do it now, but till 2003, there was no regular or routine checkup for players at all. And there was no awareness on the disease, not just on this disease, on any disease itself.
At all. So the only time you went to a doctor really was when you pulled a muscle or had an injury or things
Yeah,
like
when I pulled a muscle, had an injury, or had to had some surgery from a groin or shoulder. Otherwise, never been to a doctor. Or Pakistan Cricket Board have never sort of have this panel, doctors panel, who can see your health as well, apart from your mental health, your physical health as well.
Sure. And as a cricketer, and even now, you travel a lot. You just mentioned earlier that you travel for 6 months in a year. So how do you manage your food, your exercise regimen? How do you do
I
that?
make sure, okay, the timings are different at times. If I take 4 jabs a day, I take, Lentis 24 hourly in the evening at about 11:30. And then I have 3 jabs during the day before every meal. But I realized if I'm traveling to, say, England, it take me a couple of days to get to the timing right. So I'd say if I have breakfast at 9 o'clock here, I'll make sure I have breakfast for first day at 6 in the morning in England to get my timing going. So that's what I've learned. Nobody taught me. I've learned it myself. But eventually, with my experience of last 14 years with diabetes, whatever I have learned is that to manage your time, to manage your insulin, and of course, exercise is very, very important. And nowadays, I think our younger generation, like Doctor just mentioned, that the lifestyle matters. A young generation of India and Pakistan, even subcontinent, they have a very laid back, very easygoing lifestyle. I mean, nowadays, when I was young in class 6, 7, my mother used to, tell me, or literally kick me out, go out and play. But nowadays, kids come back from school, they have PlayStation, they have Xboxes,
Should
they
know
don't
you've got
leave.
sons.
Yeah, one of my son is like that, so hopefully he'll get to it sooner than later.
And what really works better for you? Is it your diet management, or is it exercise, and what kind of exercise?
Both.
Aerobic or
I
weights?
do weights in the morning. I haven't done any weights for a month. Like I said, I go through my phases. So hopefully after New Year's, I'll start again
Does
regularly
it
with
affect your
vengeance.
control?
No, it doesn't affect my control, but in a long run, it will affect my control. So I go for cardio in the evening, at least 45 minutes an hour. I go for a run or a quick brisk walk. But yes, and that makes me feel better mentally and physically.
And you've got 2 young boys. Have you discussed diabetes with them? Because they must have seen you on TV talking about it.
Yeah, they have. They know I'm a known diabetic worldwide, especially in our part of the world. My younger one is too young. He's 9, but he's very healthy. He wants 6-pack already, so that's a good sign. My eldest one is 13 and a half. He's a bit overweight. And I think that's where I'm trying to sort of teach him and have a word with him. Go out, play for half an hour, 40 minutes, and then do whatever you want to do. Hopefully, I'll get to it.
Do they play any sport? Are they into cricket?
They have
or
no idea about
football?
cricket, but they do play soccer, they do play badminton or tennis, but they have no clue about the game, cricket
Really?
itself. Yeah.
Do you think cricket is losing? So I have to come back to cricket. Do you think cricket is losing its popularity in the subcontinent? You know, you've had controversies surrounding it. Then we've had an overkill. There's cricket on TV every day. There's football, which is getting popular.
It's losing in popularity in Pakistan, whatever has happened in last 6 to 8 months with Pakistan cricket team. But in general, it is too much cricket. I mean, every channel you put on, every day there's cricket going on everywhere. And this T20, it's entertainment, but it's not quality. The quality is test cricket, and I think there should be a lot more test cricket and less T20, and then we have some better players at that particular level.
What do you think of the IPL? You're associated with Calcutta Knight.
IPL is fun, it's entertainment, but like I said, it's not it's
not cricket.
quantity, it's not quality.
And what do you think is a bigger threat to cricket in Pakistan? Is it the security concerns or is it the match-fixing allegations?
Both a bit.
I'm talking about the popularity,
Both a
of
bit.
course.
Of course, this match-fixing saga, whatever had happened in the last 6 months, young boys, they weren't aware what was happening. And of course, if teams don't tour Pakistan in near future, the youngsters of Pakistan, the young generation of Pakistan, they won't be able to look at their heroes in front of them. They might watch them on television, but if they can't look at them there, and if Pakistan team can't play at home, eventually Pakistan cricket will go down.
Right. Thanks a lot.
Thank you very much.
Now I'd like to invite Dr. Anup Mishra to make his presentation. He's the Director of the Department of Diabetes and Metabolic Diseases at Fortis Hospitals and is also the Director of the National Diabetes, Obesity and Cholesterol Foundation. And he's been awarded the Padma Shri and the BC Roy Award, which is the highest reward for medicine in India. Dr. Mishra.
Thanks, Sanchita. Thanks, Mrs. Bhartia and Hindustan Times. 10 years back, there was a man who had Mercedes, who had big mansions, who had industries, who had money, who had diabetes. But now, diabetes has been taken away by another man who is younger, who belongs to middle class or even lower socioeconomic strata. This is the story, I open with the story of such a person who is a 36 years old, rather young, living in New Delhi, started having severe pain in the right foot. He quickly developed gangrene of the right foot, and this is the x-ray of that leg. His leg had to be amputated. At this time, he was discovered to be diabetic. He didn't know what diabetes was at this time. He never heard of the word. This is the type of unawareness he had. Background of this person: he was a villager, farmer from the village, moved to Delhi 4 years back. From simple rotis and dal, he started having deep fried and calorie-dense food. He started working in the shop, activity levels decreased, he gained weight, and he felt tired but never went for the checkup. This is another characteristic of Indian population. After amputation, he works part-time. He spends rupees 1,000 per month for diabetes medication. Family income is totally 5,000. His quote: "Now I depend on my wife for livelihood. If something worse happens to me, who will look after my 2 children?" This is the new face of diabetes in India. India is at the epicenter of diabetes quake. The problem is as big as global warming. And you've heard earlier Sanchita saying that we have the most number of diabetics in the world. There are 51 million. Tide is still rising. That is most worrisome part of it. And you can see on the other side, urban population, steeply rising curve of diabetes. We have more people with diabetes than Australia and UK, and it will kill 1 million people in India this year. And who are these people who will be killed? These people are young diabetics. Asians are getting diabetes sooner and dying younger. Now look at this graph. This graph, the shaded area represents the most productive years of the life. And the lines which are rising represent various diseases. The first to rise, steeply increasing from 20 years onward, is cholesterol line. And then obesity, and at 35 years of age, diabetes. The age of onset of diabetes in Indians is a decade earlier than the Western population. Many are in late 20s working in burgeoning new businesses. Now, in life journey, these young people will stumble and fall early because they will have blindness, they will have nerve damage, and as you have seen, our protagonist, he had amputation of foot. This is the type of burden that diabetes in India carries because of complication, because of heart disease, kidney disease, eye disease, nerve disease, foot problem, and infection. Every year, 200,000 amputations are done in India because of diabetes, a fifth of global total. And occurrence of kidney, eye, and heart complications are 2 to 4 times genetically predisposed, more than other races. And cost is whopping 1,500 to 1,800 billion Indian national rupees in 2010. Why? Is there something wrong with our bodies? Yes, there is. We may not be as fat as many Western people, and they require, a specially made wheelchair to sit, and they will require 2 seats in the aeroplane to sit also. But we are not that fat. But our bodies have more fat, and fat is mostly located in the abdomen and inside the abdomen. Even our fat cells are fatter than the Western population. You can see on the left side are the fat cells of the Indian, which are big and like a globule. Insulin doesn't act on these fat cells. And the white people have fat cells which are smaller and thinner, where insulin can act. Now, what is the reason for this? Is it genetics, as has been outlined earlier, or is it something which has been handed over by our forefathers, over the centuries, or is it something which happens during the pregnancy? In times of plenty, which are now, our body engines are running in the famine mode. And this is the survival ploy which occurred during the famine time. During this time, energy was stored as fat. Fat is the most efficient form of energy. 1 gram of fat yields 9 calories versus the carbohydrate, which yields only 4 to 5 calories. And this is mostly stored over the abdomen. This is the most efficient form of storing energy. But the survival adaptation has now become a liability. And excess calories can neither be stored or metabolized by a small amount of muscles that we have. And this spills over in the blood and causes high sugar and diabetes. But something is occurring during pregnancy also. It is often said that diabetes in India is often born in the womb of the mothers. And how? During pregnancy, if proper nutrition is not given, there is dysfunction in the development of pancreas and arteries. And such children are born low birth weight, a common scenario in India. They are fed in excess by mothers, often anxious mothers, and they become obese during the childhood. And along with the pancreas and blood vessel dysfunction, excess fat during childhood leads to diabetes and heart disease. So something wrong during the pregnancy time also. How do we prevent? Prevention is a long and winding road. It starts with a primordial prevention. If we nip the diabetes in the womb by providing proper nutrition to the pregnant women. But there are a number of potholes and roadblocks. Now look at the unawareness of diabetes in India. On the right side are the low socioeconomic strata people. 90% are unaware as to what is diabetes, what is cause of diabetes, and what diabetes can cause. Even the upper and middle socioeconomic strata are not well aware of the problem. This is where we can tell them, we can educate them, we can empower them, and thus preventing diabetes. This is what is called as primary prevention of diabetes. We physicians are not doing a particularly good job. And look at the percentage of patients given proper diabetes education, 10%, smoking cessation only 8%, and nutritional and exercise counseling only 50%. If we do a proper job, we can prevent many complications from occurring. This is what is called as secondary prevention. The prevention is a lifetime job. They should span the lifetime. And this is the type of a typical history of a patient that we have. a patient who is given inadequate care or nutrition during childhood, during intrauterine period, and gives birth to a child who is low birth weight. And this is fed more. There is a childhood obesity. Over 10 to 20 years, insulin resistance occurs. Diabetes occurs in 26 years of age, heart attack at 38 years of age, and death at 47 years of age. We can act at each point of time here. We can act here by providing good nutrition. We can act by not allowing them to have low birth weight, by providing good nutrition. Overnutrition and the physical inactivity, the behavioral influences, we can correct all of them. And hence, by correcting this, we can delay diabetes from 26 years to maybe 70 years, heart attack from 38 years to maybe 80 years, and death maybe at 100 years. But most of the preventive strategies have to be in early life, during pregnancy and during childhood. These are the worst of the times, we know about that. But these are also best of the times, because we have new ideas, we have new energy, we have new enthusiasm, and we have new drugs, we have new concepts. Who are the people who are going to do this? Physicians or government? No, all of us. There are multiple stakeholders. And look at the stakeholders on the right side. There are government, non-government organizations, media, hospitals, scientists, corporate hospitals, pharmaceutical industries, who can work on primordial prevention by providing adequate nutrition in the pregnancy, primary prevention, spreading awareness, identifying high-risk individuals, secondary prevention by diagnosing early, providing right kind of education, by providing drugs which are cheap and widely available, and new drugs, and providing insulin which is cheap, also better devices to give insulin. And hospitals need to be more diabetes-centric, and diabetes referral and research centers, which have a wide area of coverage, need to be made. So we have new programs. This is my last slide, Sanchita.
Yes.
New programs, new guidelines, new treatment. We have hope, and it is time that we tackle all the challenges. Diabetes control program to target rural areas is a government initiative. We have one of the largest childhood obesity program where we teach children what is the right kind of diet and exercise. This is spanning 900,000 children in whole of North India. Government has announced that glucose testing strips are to be made cheaper. These are new and very, very important initiatives. We have some new regulations on trans fats in the food. We have new regulations about the exercise. We need to exercise 60 minutes per day, 7 days a week to prevent diabetes. Obesity guidelines, as has been mentioned, have been lowered for Indian population for us to act earlier and in a more appropriate manner. New drugs, this is the Gila monster, through which a new drug called sitagliptin has been identified. We are using sitagliptin. This is an excellent drug. New drugs are coming, and these are some of the drugs which are in future. And stem cell therapy, we have a number of initiatives as far as stem cell therapies are concerned, and the new way of giving insulin. So with that, I finally say that we have great hopes in the future to curb this epidemic. This is time to do that. Thank you.
Thank you, Dr. Mishra. Before I invite questions, I'm going to ask a couple of questions to our expert here, and then you're welcome to come up with your queries. Please identify yourself and keep the questions short and crisp. First, Dr. Horton, what do you think is more important when it comes to diabetes management and control? Is it exercise or is it diet control?
For prevention or for treatment or for both?
For management, prevention
For
and
management.
management.
Well, I think that both together are critically important. The vast majority of our patients with type 2 diabetes are overweight, and we recommend a heart-healthy diet focusing on decreasing fat intake, particularly animal fats, and increasing vegetables, fibers, and fruit in the diet, and losing weight. And most people can lose anywhere from 5 to 10% of their body weight. So this is really critical. Now, the exercise component, we now have very good data showing that exercise, just such as walking for a half an hour or more a day, most days of the week, has very beneficial effects on blood sugar control, but also in reducing the risk for the long-term complications, particularly the cardiovascular, heart attack and stroke, which is the major cause of mortality. So I would not say one is more important than the other. They have to go together, and they're both very, very important as the fundamental thing we do before or in addition to the use of the medications that we have.
Thank you. And Dr. Mishra, you mentioned several drugs for diabetes have come up over the last decade. How affordable are these? Can people in developing countries afford them?
Well, some of these drugs, one of them I mentioned in my slides, are now available in India for last 3 to 4 years. Well, the price of these drugs is, are at the upper end. But then these drugs have several properties which have never been seen with other drugs. So I think these are important, but these need to be used judiciously. For average diabetic, still the old traditional drugs work.
Thank you. I'd like to open the floor for questions. Please raise your hands and identify yourself. This gentleman here.
My name is Mike Singh. Wasim, Assalamu alaikum, is the lone West Indian. And you're always welcome to come back and play cricket there. The question is, during Ramadan, were you ever able to keep your roza? Given your diabetic condition? May want to elaborate.
I think this question of this answer, the doctor sahab can to give it properly, because I don't fast. I'm on insulin, I can't just risk it. But I think people who are with diabetes, with type 2, they probably can, of course, with the help of the doctors.
Well, as far as fasting is concerned, there are certain guidelines which we have to follow. We usually use drugs which do not cause too much of low sugar. And in people who are on multiple doses of insulin, whether they are Hindus who are observing Navaratra fast, or Muslims during Ramadan month, we tell them not to do the fast. But still, many people do, and then we change over to some of the drugs which are more appropriate during that period.
Right. We had a question there, and then this gentleman. Yes, sir.
My question is to Dr. Horton. What is the Harvard take on the preventive aspects of diet on diabetes? And has Harvard identified any specified foods in the diet to reduce the incidence of diabetes? Thank you.
Yes, thank you for that question. There have been a lot of studies looking at dietary composition, and many of the studies that have really looked at restricting carbohydrate in the diet have shown that you don't get as much fluctuation of blood sugar. But most of the conclusions of all of the studies is that it's caloric restriction. It's a decrease in energy intake and controlling weight that is really the critical factor, rather than so much whether you restrict specifically carbohydrates in the diet, fats in the diet, and so forth. Clearly, once you develop diabetes, we have to manage both the quantity and the quality of the carbohydrate in the diet to minimize the fluctuations in blood sugar. But for preventive strategies, there's some evidence that people on low carbohydrate diets it does tend to be somewhat protective, but it's very difficult to separate that from weight control and caloric restriction.
There was a gentleman here with a question.
Can I
Sorry.
just
Yeah, sure.
comment on this question? As far as Indian diets are concerned, there are multiple factors. Carbohydrate is one, saturated fat is other, fiber content is third, but the most important is trans fatty acid, which are present in the partially hydrogenated vegetable oils, dalda, vanaspati, and so on. And these are the ones which are directly attacking the pancreas. And so all the commercially available food in many hotels, they cook food with the PHPO. And so these are the most important, has been traditionally used in India for centuries.
Like Bengal gram and things like that.
Because Indian tradition tells us that there are certain specified foods, vegetables, etc., that prevent diabetes. But that's my question.
Well,
For instance, the role of bitter gourd, which is defined as a vegetable amongst medicines and a medicine amongst vegetables by the Indian Vedic tradition. Is there any Harvard take on that? And I guess there is, because Dr. Dina Ornish, his predecessor, has also commented on the scientific aspects of traditional Indian diet. That's
Dean Ornish, what he proposed was a combination of factors in the diet, and that too with exercise and very, very strict lifestyle, which possibly nobody can follow more than 3 to 6 months. But as far as traditional Indian diets are concerned, and you are asking for a specific constituent, then at least two stand out. And one is the fenugreek, which is methi, the other is cinnamon. And these are dalchini. These are the ones which have been researched in India and abroad and found to have some effect on the blood sugar, but at the most they can be used as the adjunctive therapy to the main therapy.
We'll move on to the next question now. This gentleman here had a question. Okay, you've got the mic, then this gentleman here.
Dr. Mishra, good to see you again. The question I wanted to ask you was that have there been studies in India to ask the question whether the genetic factors that influence diabetes in the subcontinent, South Asian subcontinent, are similar or dissimilar from those that pertain in the West? For example, are there GWAS studies? Are there any other linked genes which would distinguish these two types of diabetes, or they are more or less identical?
See, let me tell you, no particular gene will ever be found for diabetes. It is the combination of genes and interaction of gene and environment. If you ask about Indian population, there are several genes which have been identified which show that Indians have, they are more likely to cause diabetes in India. But if you ask me the quality of studies, where we need much better studies. And there are consortium of geneticists from UK combining with us in India and people in USA who are raising a large cohort where this question will be better answered.
Yeah, I'd just like to make a brief comment about this too. The work on looking at genetic predisposing factors, as Dr. Misra pointed out, is polygenic. And I work fairly closely with the group at MIT and the Broad Institute. So there's consortiums all around the world. Now there are at least 21 different SNPs that have been associated with an increased risk for diabetes, but in aggregate, it does not explain more than 5% of the risk of diabetes. So it's, we still have a lot to learn in this area.
So we need to move to the next question because there are lots of people who want to ask. Sorry.
Thank you. And I congratulate HT for putting diabetes as a subject in this discussion, which is very important for our nation. And recently on 14th, we had World Diabetes Day, and our Honorable Minister has announced a scheme in which he was going to give aid to check school children for diabetes, especially screening of diabetes. And Dr. Mishra, I was very depressed seeing that Dr. Mishra's slide which showed the most formative years.
So your
Actually,
question?
yeah, that age, I'm coming to question. How effective would be this screening of diabetes recently announced by our health union and minister would be in due course of time, and when it would be repeated? And my second question to Professor Horton is that Dr. Mishra talked about prevention in the womb. Can we do it before that in the form of counseling, premarital counseling, especially in India, in the metros? We have families in which both sides have diabetes. So how far it will be successful, a premarital counseling for diabetes and the upcoming scheme for detection of diabetes in school children, especially slum children?
See, the first question I'll answer, second question, Dr. Horton. As far as screening of diabetes is concerned, I think more important than screening is spreading awareness. This is very, very clear. Screening is costly, and screening in some of the studies have shown ultimately may not achieve decrease in the death rate due to diabetes. and some of the recent studies have shown that. But in the background of unawareness, screening is a good idea because it does the dual job. One is make person aware that he may have diabetes and it spreads the message, and the second thing is that if a person is detected to be diabetic and 50% are asymptomatic, they don't know that they have diabetes, then this person gets the early treatment.
Yeah, in the U.S., it's standard practice to test women during pregnancy, generally in the 24th week of gestation, for what we call gestational diabetes. And if it's picked up at that time, it's treated very aggressively to really avoid the increased glucose levels affecting the growth of the fetus and having large gestational size babies. And because we know that that is a increased risk factor for those children for developing diabetes later on. What we don't test for is protein malnutrition. And I really am very concerned about the low birth weight child because it's very clear that a baby who has perhaps the mother has been malnourished or other factors such as smoking during pregnancy, alcohol intake, many factors like that, that can really impair the development of the fetus, who then is at increased risk later on for both obesity and diabetes. We do not screen for that routinely. We do screen for gestational diabetes.
Right. There's a question back there and then one here.
Good evening, I'm Dr. Soin and I have a question for Dr. Mishra. You worked in two excellent centers, one is All India Institute and now in Fortis, with a different spectrum of diabetic patients. Was the progress of complications different in these two hospitals? Because normally the spectrum of patients coming to two different setups can provide a clue to that. Thank you.
What's the difference between public and private hospitals? That
Yes.
he was asking?
The scenario is quite different in both. So I worked for 30 years in All India Institute and last 4 years in Fortis. And your question is very, very relevant because in All India Institute of Medical Sciences, we are seeing middle and lower socioeconomic strata, but many people, as I showed you right in the first slide, are belonging to middle and low socioeconomic strata. But the problem with this is marked unawareness. They don't come early, they come late, and they come through a circuitous route. The route, usual route is that they go to the next quack in their vicinity. After there is no relief, they go to the next registered medical practitioner in the vicinity. No relief to a local practitioner. By the time they are getting complications and they come back to us, they are advanced stage of complication. So all India Institute patients are, they have advanced complications, some of which we cannot correct. And once they require a laser for eyes, for blindness or for dialysis, they cannot afford it. Now, as far as the corporate sector is concerned, we are seeing the people in 20s and 30s who are working in the IT industry and so on. These people, even these people are not aware, but at least once they are detected, they are able to tackle, they first come to a proper doctor or to us, and they are able to tackle diabetes in a slightly better manner. They come early and not in the late stages. So this is the type of thing that we are seeing.
Question here.
I am Atul Kumar. I have a question for Dr. Mishra. You rightly said there are certain Indian foods which will help in control of diabetes or perhaps no onset of diabetes. My question is, if somebody has a diabetes and he switches to this type of foods, will it be possible to get rid of the medication, or if he's on medicines, not on insulin, or with a good diet control, person can come back to the normal healthy life without any medication?
A very good question. If we are seeing somebody in early stages of diabetes, within 1 to 2 years, and this person is very obese, they are 110 kg or 120 kg, and we say, well, you do the diet and exercise, he loses 30 kg, and we take off all medication. We have number of Such cases, one of the cases were published by Sanchita in Hindustan Times recently. So this is possible in early stages of diabetes. But the moment diabetes is beyond 5 years, now the pancreas is totally gone. Then doing the best in the diet and exercise can control your sugar, but cannot switch you back to the normal state. Now, as far as bariatric surgery is concerned, for diabetic patients who are very obese, it totally reverses diabetes because people lose 40 to 50 kg of weight.
I just have time for 2 more questions. Can we have one from here? And
This is to the panel. My name is Sujit Panigai. I work in the area of fitness and sports. This is for school children. The idea is to identify the current level of fitness of children and improve them over a period of time. What we have seen is there are about 62% children who are either underweight or overweight, about 37% underweight. That's also a big worry, about 25% overweight. And about 62%
so your
kids
question, because we really
Yeah.
don't have time for observations.
what we have, the idea, my question is that how do you educate schools and the parents to take care of the children early on? Because when we go to schools, I mean, the reaction is it's only about education and not about their health and fitness and other
You wanna
things.
take that?
So it's
Sports?
like Washim also said that he has a son, he's overweight, but I mean, that's about how do you inculcate the behavior part to it and the intention part to it.
I think my take would be you have to create awareness. Awareness, what would be the kids? You can't tell them to exercise. They have to play some sport every day, the overweight kids. Half an hour, 45 minutes, play with them, or tell them to go out and play instead of sitting in front of a television or be a couch potato. So the lifestyle matters as this when they're young, after 11 and 12, whatever I've learned in my 15 years as a diabetic, is that lifestyle matters and of course the food matters. Both the doctors have been saying consistently that food intake is so important. And I've learned as a diabetic that at evening meal I try to miss carbs. I don't have rice, I don't have roti. I probably half a bread I have, and then I have a little bit of chicken and all, but that's all. That's you can tell kids. Healthy lifestyle, exercise, and of course some sport.
The kids, they have the knowledge, they don't have the intention. The behavior may be there because they are forced.
No, but
So
I
how
think
do you
what he's
build in
trying to
the
say is
intention?
that you also have to play with the kids. I mean, you can't sit and watch TV and expect your children to be physically active.
Yeah,
So
see-
parents have to set an example as well.
See the 34 crore children going to school in India. How do you do that with the schools? Because the schools don't
Should invite
understand.
Wasim for talks, I think.
Yeah, I don't mind
Can we have
doing
the
it.
last question, please?
Yeah, but I can tell you, we have done it in the school. Using a module, we have shown successfully that within 6 months, if you intensively educate children, you can change their metabolic profile, you can decrease their weight, everything has been done. This has been published paper, so we can talk about it later on.
Okay, there's so many hands all of a sudden. That gentleman standing in the corner there.
Dr. Mishra, you ended your presentation with the initiative for the stem cell therapy. What exactly is being done? I mean, there is always this ethical question, but there is also this question of so many people who are diabetic who can be treated well with the stem cell therapy. What are the initiatives? Thank you.
So there are 3 areas in the stem cell which are being worked upon. One is the type 1 diabetes, where the pancreas is totally destroyed, and there are some studies which have been done in the US show that by giving stem cell, there is the insulin treatment can be delayed or avoided altogether in type 1 diabetes. Type 2 diabetes is more difficult because it's a heterogeneous disorder and mostly lifestyle related. But one study in India from PGI Chandigarh has shown that some improvement in the stem cell, but that's far from satisfactory. The third area is diabetic foot ulcer, which is highly resistant to the treatment. It goes on and on, getting infected time and again, produces gangrene, amputation has to be done, the blood supply is bad, the nerve supply is bad, and so on. Here, local injection of stem cell, that's what we have done, we are doing at the moment. A stem cell can help increase the blood supply and help heal the wound. So these are 3 areas, all of them are experimental, nothing is available commercially at the moment.
I have to end the session now. The experts are around. You can always ask them questions later. I'm sorry we are way over time. And thank you all for coming here. I think the take-home message from this session is you have to eat healthy, you have to exercise at least an hour a day, which is quite a bit, and manage and prevent diabetes. Thank you.
Thank you very much. Thank you to our experts. If you could just remain here, and may I request Mr. Shashi Shekhar, Editor-in-Chief, Hindustan, to please come up and present mementos to our guest speakers. Thank you, gentlemen. Thank you, Sanchita. Ladies and gentlemen, we've come to the close of the first day of the Hindustan Times Leadership Summit. We begin tomorrow at 10 a.m. and as the Prime Minister will join us for the first session, I request you should all be seated inside the hall by 9:30, so please ensure that you're here on time. Thank you very much, and we'll see you tomorrow.